But it's my pleasure to introduce our speaker today. This, by the way, is this the third TREET seminar? So it's really happening. Thanks mostly to Danny, who's really done a terrific job of organizing this. Yes.
We actually have one going on.
Yeah, I mean, don't act too surprised, Florence. You make people.
We've got 3 of these. I mean, there are other ones, but this is really quite different.
So, in any case, I mean, many of you know Dr. Carolee Winstein, but let me give you a brief introduction to her and to her work. She is a professor in the Division of Biokinesiology and Physical Therapy. She is a physical therapist. She got her physical therapy degree at UC San Francisco. And I think she also had a bachelor's degree at UCLA, got a master's degree here at USC, and then got her PhD at UCLA in what was then the Department of Kinesiology, and her mentor was Dick Schmidt, who's one of the foremost one of the people who put motor learning on the map back in the 1970s and 80s. From there, she went on and did a postdoc with Jim Abbs at Wisconsin, and came back here and joined the faculty here sometime back in the late 80s or so. Is that right? Early 90s. And Carolee really, during that period of time, published some seminal papers that really were instrumental in getting people in physical therapy and in rehabilitation to think about motor learning principles as we take this for granted now, but back then people didn't think motor learning had anything to do with how you might treat a patient. And her work was really instrumental in bringing those ideas into the rehabilitation community. Since then, and really starting about 10 years ago, she moved into clinical trials research. She was involved in the Excite trial. She was a assistant director of the Excite trial, which was a multi-site clinical trial that looked at constraint-induced therapy. She was the PI and director of a clinical research network, which we got funding from the Foundation for Physical Therapy, $1.5 million to start that, and really put together our clinical trials infrastructure here in biokinesiology and physical therapy. And she's been on a number of other clinical trials. Currently, she's the PI of a clinical trial called iCare, which is really the next step after the constraint-induced therapy trial, a trial looking at an intervention for treating upper limbs of patients with stroke. So she's received many honors in the physical therapy profession. She's had many awards and honors, and she's a fellow of the American Physical Therapy Association. And 2 years ago, she gave what's called the Catherine Worthingham Lecture, which is an annual lecture given by somebody who's a recognized leader in the profession. So she really is somebody who, in rehabilitation, has a very strong voice and has made a very strong contribution. We're very lucky to have her talking to us this morning.
Thank you, Jim. Now I've got to see how well my motor learning went from the one practice session I had. And I guess it's on already, right? So It's really a pleasure to be here. Of course, I am here. I'm just down the hall, but I didn't have to get on an airplane, which is great. So when Danny called me and asked me for a title, I gave him the first part of this title. And then I decided that was really boring. And so I decided that a subtitle would be The Good, the Bad, and the Ugly, so that I could keep your attention during the lecture. So what I'm going to do, and I want to also say that I will entertain questions, so you can interrupt me if things come up that you're curious about. I'm going to give a brief introduction, provide a very small piece of background and context for the trials I'm going to talk about. My focus, as a caveat right away, is in neurorehabilitation and primarily in stroke rehabilitation trials. There have been a lot of other areas that have moved forward, and a lot of that work has been done here. But I'm going to focus mostly on stroke rehabilitation. I'm going to characterize where we are now with respect to clinical trials research in neurorehabilitation and stroke. I'm going to give a brief primer on randomized clinical trial design and the staging of clinical trials, which I think is an area of confusion to most people. And then I'm going to appraise the trials that have been done by categorizing them as the good, the bad, and the ugly, with a little bit of poetic license. The examples I'm going to talk about are the STEPS trial, which was part of PT ClinResNet. It was a phase 2 trial. The other trials I'm going to talk about, Silt was spinal cord injury, the Excite trial, the VA robot trial, and the LEAPS trial were all phase 3 definitive trials. So we'll talk about what that means. I'm going to spend a little time talking about what we learned from what are called negative trials. I think the clinical community has a different interpretation of a negative trial than the clinical trial community. So I want to talk a little bit about that. I'm going to summarize the challenges and opportunities there are for being involved in clinical trial research that I think will resonate with many of you here. And then I'm going to give 2 examples of secondary analyses that were made possible by the databases that were developed from these clinical trials. And then close with what I think the future direction in this area should be. So where are we now? And I think we can't ignore the fact that several seminal discoveries in basic science really stimulated the development of therapeutic interventions. There is no denying that the evidence that the adult brain retains the ability to modify anatomical and functional connections as a result of learning or injuries has had tremendous impact on our thinking about how to design interventions to affect recovery. And that really has happened over the last, I would say, 15 or 20 years. Some of these changes in brain have been associated with functional recovery. And that is especially true when it is coupled with behavioral training. In other words, without training, you don't see these important neuroplastic changes, but with training, you do. And so there is some very compelling evidence beginning, I think, with the seminal work of Randy Nudo back in the mid-90s, where he showed using very detailed recordings of the motor cortex in the primate that when the monkey was trained on a very controlled task to pick up pellets, that you saw pretty phenomenal changes in the cortical representation of the fingers. That was not the case when the animal was just left to recover sort of on its own and not put through this controlled training. And that really stimulated the thinking in this area. And from that, we now have some well-designed phase 3 randomized clinical trials. These are called definitive randomized clinical trials, that use a rigorous scientific approach to provide evidence to inform clinical practice in neurorehab. And I highlighted this point of rigorous scientific approach because I think this is something people don't understand when they look at how these trials are analyzed and the rigor and constraints that are in place in order to make them happen. And I'm going to talk a lot about that throughout with the examples. So why do we need these explanatory RCTs? Explanatory is another term used for definitive RCT. And the reason is that a strict explanatory RCT design is used to reveal cause and effect relationships. So if we want to know that X intervention directly causes an outcome that is beneficial, we can really only address that if we use a explanatory RCT. Now, the conundrum that we have is that our practice is really complex. And so the relationship between what we do in a clinical trial and how practice that we are trying to provide evidence for takes place, there's a big gap between those two things. So the way clinical trialists think about the clinical trial phases is really an integration of both quantitative and qualitative methods. And if you think about it, you really start with a phase 1 trial that is probably more of an observational type trial. You also use observational designs in the 4th stage of clinical trials that I know there are none in rehabilitation. And these are the long-term effects of some sort of an intervention or a drug. We haven't been in the business long enough to really do those kind of trials. The phase 2s are usually exploratory and much more quantitative in nature. Notice that phase 3 can be either explanatory or pragmatic. And I'll explain the difference between explanatory and pragmatic. I'm going to talk primarily about explanatory trials in this talk, but I want to mention pragmatic. You can see that pragmatic can also be phase 4. So the methods can be quite different. And I recommend this paper. It's a short paper, but it's really well done.
Sorry, in that paper, are they talking about pharmacological interventions in general?
No, they're actually talking about complex interventions in rehabilitation. So that's why it's a really good paper for us, I think. So I want to map this idea of explanatory versus pragmatic to this notion of efficacy versus effectiveness, which I think sometimes these terms are used synonymously, and they are not the same at all. So when assessing efficacy, you're really asking, does a treatment work under ideal, highly controlled, optimal conditions? And that's the way most explanatory trials are designed. And so when you're in the middle of an explanatory trial and your clinician that's out there at one of the sites says, but this is not how we do it, you have to remind them that this is part of an explanatory trial and that these constraints are very, very important in order to maintain the ability to ask the question about cause and effect. If you are interested in effectiveness work, and there is a new growing emphasis on comparative effectiveness research, which is much more, does a treatment work in the real clinical situation where for a variety of reasons treatment application and adherence may not be ideal, because that's really the real world, right? So, and this is where the pragmatic trials live. Pragmatic trials are more qualitative. They have less constraints, and they are particularly interested in effectiveness in the real world with all this variability. The explanatory trials are on this end of the spectrum. They're assessing efficacy, and they have considerable controls built in order to do that, including the intent to treat analysis, which basically says that's the first level of analysis that's done in a explanatory randomized clinical trial, and that's what's required by the funding agencies. And what an intent to treat analysis says, it's a very conservative analysis, is that the data are analyzed based on what group the individual is randomized to. Doesn't matter whether they got the intervention or not. Doesn't matter if they didn't show up for any of the assessments. Well, they would have had to have shown up for the assessments to have data. But doesn't matter if they decided, I don't want to do that, I want to do the other group. You still analyze this with assuming that that person was randomized to that treatment, and that's how we're going to look at the data. And why do you think that's done? Why do you think that's done? Why is that that's a conservative analysis? What metric has to happen then? So if I find differences using an intent to treat analysis between treatment A and treatment B, what does that tell me? And I've got people in there, Clarissa?
The effect of the treatment is so profound that even with this outlying data that you can actually say that there is an effect there.
Yeah, so even with the noise that is introduced by the fact that this individual didn't receive treatment A, you still have an effect. So that's what I mean by rigorous scientific design. So the rigor, so when you see differences in an explanatory trial, they're big and they're meaningful, and they then warrant consideration for changing practice.
I think it also has to do with generalizability. So
Yes.
for any intervention, there's always going to be people in the population who aren't going to show up. Or
That's right.
Just want, the assessment money and drop out, or going to hate the intervention. So you're not getting a sample that's really, like tailored to the best possible person. So I think that's
Yeah, and I think it's also a way for the explanatory trial to meet the sort of conditions that are necessary for the real world. If we're going to translate these things into the real world. So, but that has impacts, right? I mean, that means your intervention needs to be pretty robust.
But what people do to get around that now is they give a readiness to change scale before, and they set that as a criteria. So if you're not
For the
ready to
individual?
change, you don't get.
Oh, that's a really interesting, that's an interesting,
People do that, and that's how they do it in the social, psychological studies
Yeah.
to boost the success.
yeah. So that's part of the inclusion criteria, like a pre-screening.
A certain score on
Yeah.
readiness to change.
Uh-huh.
So you can get rid of all the people that you think aren't going to do it.
Uh-huh.
Right. So for every problem, there's always a way to get around it, but it takes a while for people to do it.
But the point is but the point is you have to get around it in advance.
Right.
One of the things that the
Right.
intent to treat does above all is it really prevents manipulation of the data and deciding, okay, well, these people who didn't accept, I'm not going to include them because but these people over here, I am going to include them because I think they.
Which is what people do with phase 1s and phase 2s.
Right.
I mean, that goes on all the time. You get rid of outliers. You say, well, this person didn't show up, or they didn't really want this. So that's the point, really, is that the rigor is pretty high. So this is figure that is from the same paper and shows the progression of clinical trial research coming from theory to modeling to exploratory trials to definitive RCTs, which are, in this case, explanatory, and then long-term implementation. And I wanted to show you this because I wanted to bring your attention to a couple things. So the theory that has driven a lot of the research in this area comes from two major areas. Probably the most is the experience-dependent neuroplasticity, and I just bring your attention to a very nice paper by Klein and Jones that sort of characterizes this area. Motor learning, learning and memory research has also motivated research in this area, and more recently, the notions of self-efficacy, management, and motivation have begun to inform some of the work in this area. The modeling piece, we actually just started a phase 1 trial that is truly modeling the different doses of therapy required to have an impact using a train, wait, train design. There have been other models, computational models, animal models, mechanistic studies. This is really where these kinds of trials are. The exploratory trials are phase 2s. I'm going to talk about one of them that was part of PT ClinResNet. The vector study, very early constraint-induced therapy, run by Alex Dromerick. The Cirros study, which I have put into the ugly category, and we'll talk about that a little later. And then I'm mentioning here a recent study by Jill Whittle and her group, BATTRACK, compared to a dose-matched therapeutic exercise group. Our STAR study was a phase 2 trial. Usually what happens is you do phase 2s in order to understand your outcome variables, in order to be able to calculate power for larger trials. And so it allows you a lot more room for exploration. And basically how Campbell and their group describe this phase, is that it describes the constant and variable components of a replicable intervention and feasible protocol for comparing the intervention to an appropriate alternative. So that's where you're really coming up with your protocol. Now I want to, I forgot to mention that this applies primarily to complex interventions. So this is not, the paper was written really dealing with complex rehabilitation interventions. But I want to define what it means to, what a definitive RCT has to have in it. And that will help, I think, people understand what has to happen before. You can't just go out and say, oh, gee, we want to do a definitive RCT on X. Wouldn't that be nice? You have to really have built up in that area. So the definition is that you are comparing a fully defined intervention to an appropriate alternative using a protocol that is theoretically defensible, reproducible, and adequately controlled in a study with appropriate statistical power. That's the argument you have to make to the funding agencies in order to get funded to run these kinds of trials. So you have to really do your homework. You have to provide information for the fact that your intervention is fully defined. You know, there are no questions that you need to continue to answer here. That you're comparing it to an appropriate alternative, and that's really important here. I'm going to talk a lot about that. That doesn't mean it's a no treatment control group. At least it doesn't mean that anymore. And that's really what's changed in the so why, we've come a long way. We now have a bank of these trials that have been done, and we couldn't say that a decade ago. So why do we say the good, the bad, and the ugly? Well, one was to keep your attention. Two, I think it's always good to assess where we've come from and what were the problems and where should we go and what have we learned from this. So I have taken the liberty of categorizing the trials into these three categories so that I can keep your attention, and you'll say, well, now what was the bad and what was the ugly? All right, so let's start with the good news. So examples that lay a foundation, as Jim mentioned, we, back in the early 90s, had an opportunity to put together a proposal to the Physical Therapy Foundation to put together a clinical research network. And this was our first foray, really, into this. And when I think back on it, I think we sort of knew what we were getting into, but I'm not sure we totally knew what we were getting into.
But it wasn't the early 90s.
I'm sorry, it was the, right.
Early 2000s.
Early 2000s, sorry, I was thinking decade. Yes, it was the early 2000s. There was a $5,000 planning grant. We got together interested colleagues who had a track record, and then we ended up putting together this proposal, and we won. And we elected to start. This was a 3-year, only 3 years to run 4 RCTs. But the foundation gave us $1.5 million, and I'm going to talk at the end about the institution put in quite a bit in order to make this happen. So that's an important point. The trial I'm going to talk about is the STEPS trial, which was a strength training effectiveness post-stroke. It was a phase 2 RCT. It was the only one of the network that was a phase 2. The rest of them were phase 1s, and that tells you a little bit about where the research in this area was at the time. The only one that was advanced enough to be able to go to an exploratory trial was this strength training effectiveness post-stroke. I'm going to talk about the Silt trial, which was a spinal cord injury locomotor training. It was completed. Bruce Dobkin was the PI. The findings were published in Neurology in 2006. So just look at the dates of these publications, kind of see that we have gotten a reasonable start. The Excite trial that Jim mentioned, I was involved with. Steve Wolf was the principal investigator from Emory. And it was completed, the primary outcome paper for Excite came out in 2006, was published in JAMA, and then we have had 3 additional papers that are the other specific aims from this trial that have been published in Stroke and Lancet Neurology. The last one came out in last year. The VA robot-assisted therapy phase 3 randomized clinical trial, it was a multi-site robot study using the MIT Manus robot. And this was initiated in part because the VA has a very nice infrastructure for running trials. They already have this in-place network. And so it was able to serve this trial very well. Its findings were published last year in the New England Journal of Medicine. And finally, the LEAPS trial that some of you might know quite a bit about because a good portion of it took place here in California, was the locomotor experience applied post-stroke. The findings were published earlier this year in the New England Journal of Medicine. The common thing between all of these is that they all investigated the effects of a complex intervention. So here's an overview of the network, PT ClinResNet. We had a considerable number of network sites affiliated. I'm going to talk about the STEPS trial. PEDALS was pediatric and endurance training in children with cerebral palsy. This was an orthopedic study. It was the microdiscectomy study. This is my favorite name because it's an invertebrate. So these were people recovering from microdiscectomy. And the STOMPS trial I'm going to mention briefly at the end was strength training and optimal movements post-spinal cord injury. This was really Sarah Mulroy and Brian Kemp were the leads, and Lily Thompson. And this is the only one that had a single site. The rest of these had multiple sites. We had a central data management and analysis core that was directed by Stan Azen and his group. That was critical. We had a scientific advisory panel, and we also had a data monitoring and safety committee that we reported to on a yearly basis. So we were really simulating what one would do in a phase 3 kind of environment. So the common operating principles, why were these not just 4 independent trials, was that we used the International Classification of Functioning and Disability framework to determine our outcome measures. So everybody had a primary outcome, but we also had at least one outcome at the levels of the ICF. And this was in anticipation of being able to do some work at the end with our databases that would determine the causal relationships between the levels of the ICF. So we might make a change in muscle performance, which is at the impairment level, but what is the effect of that change on someone's activity level or their participation in meaningful activities? That was the kind of thing we were trying to get at. We wanted to, so the design of all of these was based on scientifically sound principles to enhance muscle performance and functional motor skills. And that is what went into then the protocol development for each of these trials. We wanted to maintain the scientific rigor while not compromising the clinical meaningfulness or applicability of the work. And that was really, that was difficult, but always in our mind. All of the trials took place in the clinic. And so this was a matter of doing a lot of education and had a lot of cooperation with our clinical sites. And what I kind of view this as maintaining a balance between efficacy and effectiveness. So while we allowed in some variability by virtue of the clinical environment, all the therapists were standardized, so we knew they were delivering the intervention at a level that was acceptable, and we had pretty strict inclusion-exclusion criteria. So we're not just letting anybody in. We published two of our protocol papers, which I think is a very important part of this field, for people to take the time to actually publish the protocol so that others can use it. So the Petals group published their protocol in BMC Pediatrics. There are now several journals that do this, and it allows your colleagues, before your results are out, to really look at the details of your methods and your design. What this also does is when you write your primary outcome paper, you can't obviously go into as much detail as you do in your protocol papers. And so you can refer to the protocol paper that has a lot more details about what was done and what your hypotheses were. The muscle group also published their protocol paper in BMC musculoskeletal disorders. So let me talk briefly about the STEPS trial. Our clinical question was the specific aim was to determine the effects of combined task-specific and strength training interventions to improve walking ability in individuals post-stroke. So it was a combined, so the subjects came in 4 days a week, and on 2 days they got very specific task-specific training, either body weight supported treadmill training or a cycling regimen that was on a special cycle that provided resistance as they cycled. And on the alternate days, 2 of the groups also got strength training exercises, either lower extremity exercises with TheraBand, or they got the cycle. So one group had bodyweight supported treadmill training on 2 days, and on the other 2 days they got the cycling regimen. And then we had a fourth group that had bodyweight supported treadmill training and a sham, which was an upper extremity cycling. You don't really need to know too much of the details. The clinical question, the first clinical question was, can similar gains in walking outcomes be achieved with a less task-specific limb-loaded cycling regimen compared to a more task-specific intervention? So in this case, we were really looking at bodyweight supported treadmill training as a task-specific training. And the answer to that was no, not for walking velocity, but yes for walking endurance. So we did not see the benefits of cycling alone on walking velocity, but we did see that both of these programs had similar effects on walking endurance, how long somebody could walk. The clinical significance of the body weight and the cycle comparison was basically this, that the body weight training resulted in improvements in walking speed and endurance, and it was support for the benefits of task-specific training. The cycle resulted in similar gains in endurance, but not walking speed. So it was support for an alternative therapy option to increase endurance in people who maybe could not walk or could not participate in a walking program. That's this is the clinical interpretation of these results. So it gives the clinician another alternative if they're interested in increasing one's endurance. The second clinical question was, does lower extremity strength training, either using the cycle or lower extremity exercise combined with body weight support, result in increased walking speed or distance compared with body weight support alone with this upper extremity sham? There are 3 of the 4 groups had body weight supported treadmill training. 2 of them had the additional strength training. And our naive thinking was, well, more is better. So we add strength training to the body weight supported treadmill training on the other 2 days, and they're going to be even better at walking. So it turned out that was not the case. There was really no difference between the 3 body weight supported treadmill training groups, even though 2 of them had strength training. So strength training alternated with body weight did not improve the outcomes anymore. And this is where you want to then go back to a mechanistic design and try and figure out what was going on. The clinical significance of this was that body weight support training resulted in a clinically meaningful change with or without the addition of a strengthening program. And this is close, but it is significant, that over 50% of the individuals that we had data on, there were originally 60, but we had 53 with full data. 27 out of 53 were classified at a higher functional walking level post body weight supported treadmill training. Now you can see here why this is a phase 2 trial. This is promising, was statistically significant. And this was, more importantly, maintained at 6-month follow-up. So there was a follow-up. And this paper was published, the primary outcome paper was published in 2007. Kathy Sullivan was the lead on this with her team from the STEPS trial. There were a couple other things that came out of the STEPS trial. I'll talk about one of them at the very end of this talk. But there was also a case study that Kathy published, a single case where they really analyzed in much more detail the task-specific training and strengthening effects on locomotor recovery post-stroke with Tara Klassen, who was a master's student with us at the time, and Sarah Mulroy, who was the lead on an ancillary study to STEPS that I'll talk about later. So now I'm going to leave that and talk about the Silt trial. This was a very controversial trial when it was published. This is the primary outcome paper that came out in Neurology in 2006. Weight-supported treadmill versus overground training for walking after acute incomplete spinal cord injury. So now we're shifting to spinal cord injury. Their objectives and this is the first phase 3 trial I'm talking about, so pay attention to the details here. Their objective was to compare the efficacy of step training with body weight support on a treadmill with overground practice to the efficacy of an equal amount of overground mobility therapy. That was their control group. Okay? So equal amounts, dosage is equal here. In patients with incomplete spinal cord injury admitted to inpatient rehabilitation. Now, why was this so controversial when it came out? The conclusions were that the physical therapy strategies of body weight support on a treadmill and defined overground mobility therapy did not produce different outcomes. My Skype is on, and so I'm getting information on everybody who's on Skype. So they did not produce different outcomes. And the trial was a superiority trial. The hypothesis was that the body weight support group would be better than the overground practice group, the dose equivalent overground practice group. There was an unexpectedly high percentage of Asia C subjects who achieved functional walking speeds irrespective of their treatment. So here's how when you do it right and you use rigorous scientific control, you often see things that you don't expect because you've been a little biased in what you think is going on. The good news, in my view, is that these results provided new insight into disability after incomplete spinal cord injury. So what were these patients capable of? This is a really important finding. And it affirmed the importance of the multi-center randomized clinical trial to test different rehabilitation paradigms.
So there was no control for the second point?
There was no control in this. So there was no standard practice group, which there was in the LEAPS trial. So that's another point. But the importance of this is that there was a dose equivalent group here. So the hypothesis was that there's some special ingredient that is embodied in the body weight supported treadmill training that is superior to the standard practice, and that did not pan out.
Not everyone may understand what agency means. Why that finding is significant.
So normally these people, anybody here with spinal cord injury? I don't know the definition of Asia C, but these people normally, so they have a level of injury that you might not predict that they would recover walking as well as they did, is the idea. So D's are cauda equina, C's are, do you know the definition? Right, so they have some motor recovery. Jane, you might know. So this was a little bit unexpected in their results. So I want to go on and talk about the EXCITE trial. This is the last trial you will ever see that has a no treatment control group. Now, we were going on about the same time as Silt was going on. And I think the Silt trial was published slightly before the EXCITE trial. I'm not going to go into the details of this trial. I think everybody pretty much knows this. But this, at the time, when we got funded in 2000, we actually began the trial in about 2001. And so you know, these are 5-year trials. We had about 222 people enrolled. It had an immediate group and a delayed group. The immediate group got, these people were 3 to 9 months post-stroke. So they had, for all intents and purposes, they had finished their rehab and were discharged and were living in the community. The average was about 6 months post. and they were brought back in. They either got constraint-induced movement therapy for 2 weeks right after being enrolled, or they got randomized to the delayed group, which got this 2 weeks intensive therapy a year later. So they essentially served as the control group for the 1-year outcome. And then we looked at the effects of constraint-induced movement therapy delivered a year after the immediate group got theirs. And that's the paper that was just recently published comparing the early and the late. But for the primary outcome paper, we were comparing the folks that got 2 weeks of intense training, 60 hours for 2 weeks at their 1-year outcome time point, to another group that basically got nothing, right? So no surprise that we published our protocol paper in 2003, and the editorial for our primary outcome paper was that the EXCITE trial was the first multi-site randomized study to demonstrate the efficacy of a rehabilitative intervention. It therefore moves neurorehabilitative care into the area of evidence-based medicine, because this is what the medical community looks for. They look for phase 3 evidence that a rehabilitative protocol is beneficial. So, and what Andy Luft and Dan Hanley said, as the first large controlled trial in neurorehab, the study leaves important questions for future trials. And I think this is really an important point. So first of all, if we hadn't seen an effect, then there'd be something really, really wrong, right? Because we're comparing this intensive program to basically nothing. I mean, we gathered evidence for what the delayed group was doing during that interval, and it was really minimal. You know, they might be getting a little bit of therapy here and there, but it certainly was not at any level of intensity. So, but we didn't show that there was anything specific about constraint-induced movement therapy that was beneficial, right? Because we didn't have any other comparison group. We didn't have a group that didn't wear a mitt. We didn't have a group that got half the amount of therapy, half the dosage. So all we have is this very, very intense dosage of therapy compared to nothing. And I think that's really the take-home message of this trial. Then our subsequent papers, comparing early and late, I can give you the bottom line for the early and late. It didn't matter. They both got to the same time point. So remember, early was still late. It was 6 months post. So if you're thinking about impacting neuroplastic changes, you're probably going to want to move a little earlier in the time point, which means you're going to be abutting against the period where people are getting standard therapy. That's what the eye care trial is about, and there's a lot of issues with that. So, but we are handling them, but it is another complication that's added to the mix. So you're doing a clinical trial during the same time frame that their insurance is paying for their rehab. Right? So Medicare pays for, 6 visits or 8 visits of outpatient therapy. So then you're intervening with a trial. So who pays for that? The patient says, well, but my Medicare is going to pay me to have therapy. What if I get randomized to the, to the dose equivalent group? Then, and I'm supposed to get 30 visits. What if my insurance is only paying for 6? Then does the study pick up the other? So we tried that, and it's a nightmare. It's an absolute nightmare. So that's a problem. There's a problem with waiting lists. So people get randomized, and then they have to go on a waiting list, or they have to get evaluated by Medicare to see, whether they're eligible. It's really, and we've really tried. So we basically said, okay, the study's going to pay for everything. we're not going to, and we're not going to mess with that. But, there are these sort of practical implications. It's a lot more complicated if somebody is, receiving services and those services have certain constraints and requirements. Yes?
But the study paid for everything, but the 6 extra sessions, they did not get. I mean, whatever was paid by the insurance, it didn't start with everybody when they did that.
No. We had to, obviously, we had to control that. So in the dose equivalent group, and we're in the middle of this, they have to get 30 visits of outpatient therapy. So we're just saying they're going to start their 30 visits once they get randomized. And if their insurance is going to pay for it, that's okay, but we're not going to wait for that. And we're not going to really deal with it. We tried to do a hybrid where insurance would pay and then we would pick up when insurance left off, and I can tell you that it's not going to, it doesn't work.
So you incorporated what the insurance was paying into the 30 visits.
They didn't have 30 plus.
Yeah, no, they didn't have 30 plus, no. And we have constraints on how many outpatient visits that they can have before we only allow a maximum of 6 before they get randomized, start the trial. So we had to go to a lot of different issues to try to keep this, and this is the issue of practicality and also blending this kind of research into the real environment. It's not easy. So I want to talk now about this multi-site robot-assisted therapy trial. This was Al Lowe was the lead, and this was testing the MIT Manus robot for upper extremity aiming movements in people with chronic stroke. And the results of this trial were in patients with long-term upper limb deficits after stroke. Robot-assisted therapy did not significantly improve motor function at 12 weeks as compared with usual care or intensive therapy. They had a movement-matched intensive therapy group. But in secondary analyses, so 12 weeks was their primary outcome point. But they did some secondary analysis on a later outcome point. Robot-assisted therapy improved outcomes over 36 weeks as compared with usual care, but not with intensive therapy. So their dose-matched intensive therapy provided by a therapist at 36 weeks was equivalent to the fancy, expensive robot therapy at the same time. But they were both better than usual care. In fact, they were so much better than usual care that the interim analysis, which is often required by the funding agency, at that point they had these robust differences. They dropped the usual care group because these people were not benefiting at all. But you can also imagine that they probably weren't getting anything because these are chronic stroke patients. So again, you're comparing to a no therapy intervention group. So hold all this, because I'm going to tie it all together in a minute. So now we flip to the LEAPS trial, which really was informed by a lot of the previous work that had been done on body weight supported treadmill training. Notice the name is different. Locomotor experience applied post-stroke. So it's not just body weight supported treadmill training. Body weight supported treadmill training is part of the locomotor experience that was used in this trial. Pam Duncan was the principal investigator. Kathy Sullivan here was a co-principal investigator, and Andrea Bierman from the University of Florida. LEAPS was specifically designed to address the following questions. In addition to usual care, to determine if a specialized locomotor training program that includes body weight support as a treatment modality can produce clinically significant changes in walking speed in individuals post-stroke compared to a home exercise program. Secondarily, they wanted to determine the effect of timing So two of the groups began their locomotor training either early at 2 months post-stroke or late at 6 months post-stroke. And severity. So they stratified by, I believe, lower extremity Fuglemeier into moderate. I'm sorry, they stratified by gait speed. So they had a threshold for gait speed. So they were either moderately involved, depending upon their initial gait speed, or severely involved. And duration. So they actually looked at the data at 12 weeks, 12 sessions, 24 sessions, and 36 sessions. So this was a repeated measures. They didn't stop people. They used these as evaluation time points. Their primary outcomes were successful recovery of walking for persons with initial severe gait impairment or as having achieved a 0.8 meters per second gait speed or greater for persons with initial moderate gait impairment at 1 year post-stroke. They wanted to determine if the timing of locomotor training delivery affects the improvement in gait speed at 1 year and whether initial locomotor impairment severity interacts with the timing of locomotor training. So this was they were probing whether or not there was an interaction with timing and severity. You might hypothesize that the more severe people might benefit if you intervened later than the early group. So they also published their protocol paper, and you can read the details of everything they did in this BMC Neurology. And these are the results, which I find very, very interesting. And this trial also created an incredible controversy in the clinical community because in some sense they were surprising. So let me take you through this a little bit. These are everybody. These are the severe group, and this is the moderate impairment group. What you've got down here is the screening, 2 months, after 12 sessions, 24 and 36 sessions, 6 months, then 12, 24, 36, and then 12-month primary outcome. The colors are the early locomotor training group is the brown. I'm following it right here. And you can see it closely follows the black, which is the home exercise group. The blue is the usual care group. The blue is the group that is the late group, essentially, because they're getting usual care until they turn around at 6 months. Okay? Everybody with me?
And you might mention the home exercise group.
Yes, so this was a intensive home exercise regimen. This was a progressive, intensive home exercise program delivered by a therapist in the patient's home. And it was in no way, shape, or form looked like usual care, even usual home care. Yes? So usual care is pretty much whatever happens, and you know that is all over the map. This was, I believe, 3 days a week for an hour of progressive, intense therapy, which, believe it or not, looks very, very different from home care. I mean, they were on task for an hour. They were, doing strengthening exercises. They didn't actually do much gait training at all.
Were they giving like any home program?
Yes, yes. So it's how you would design a home exercise program that you, thought would be effective, really. So they used all, their knowledge to design this really dose equivalent. It wasn't called a dose equivalent, but it was an intensive, progressive this is the other thing. And Pam has really found this in her previous work, that if you look at home exercise programs that are routinely given in clinical practice, they're not progressive. They're not progressed. So you give somebody a set of exercises and they do those exercises and there's no progression. I mean, it's very sad what's out there. It's pretty sad. You were going to ask a question.
Is it chronic?
No, these are, remember, these are the early group starts at 2 months
Post-stroke.
post-stroke, and the late group starts at 6 months. So they're in a relatively early period, but this temporal dimension was 2 and 6. So 2 is still within the time frame of when these people are probably around, and maybe even some of them, well, they're discharged for sure. They're not in inpatient therapy, but they're getting outpatient therapy.
Was there a directional hypothesis or
Yes, yes, and I'm going to talk about that. There was a direction hypothesis. I'm going to talk about that. It's really important. Okay, whoops. So so the trend here, not the trend, but the results, no matter which group you look at, is that the home exercise group, which is the black, and the early locomotor training. So the home exercise started early, right? They didn't have it wasn't a completely cross design. So they essentially are the same, and they come out the same at 12 months. The home exercise group, the black, and the early locomotor training were no different at 1 year. And that's true no matter where you look at it. What's interesting here is the blue, you see, this is the group that's randomized to the late locomotor training. So they start being followed, but they're not getting intervened with by the trial until they turn over at 6 months. And then you begin to see them improve, starting here. And they get up to the level of the other two groups by 1 year. So this sort of says to me, the potential is here, and our standard clinical practice isn't capitalizing on that potential. So if you do sub-analyses and you look at 6 months, there's a statistically significant difference between the late and the early, because the late's not getting anything at this point except usual care. So that was a nice, I think, finding. The other nice finding was that there really wasn't a difference between the intensive home exercise group and the body weight supported treadmill training, and the clinical community was very, very upset by this because there was a superiority hypothesis. So let me summarize here and say where we are. We have a good beginning. We have the capability to develop appropriate evidence-based protocols for definitive RCTs. I've showed you that. We can assure fidelity of complex interventions across multiple sites. This is really important, but it involves intensive standardization across sites. A no treatment control is no longer an acceptable comparison group. So you would never get a design like Excite funded these days. It just wouldn't happen anymore. So, and in some sense, I view that as good news because it says therapy does benefit people. Nicholas.
Yeah, I don't understand the difference between Excite and LEAP programs, because everybody got therapy in Excite.
Right,
They were just delayed.
right. But our primary outcome was 1 year. And so we essentially, the no treatment group was the comparison group for that. So we had secondary analyses that went, for 2 years, and we compared early and late. But so LEAPS had this nice design whereby they intervened at 6 months. Their primary outcome was at 1 year. So they kind of broke up this control group, which I thought was a really nice design. So they were able to show that these people had potential, but yep.
So I know this is going on, I just got things that's on a trial, and we got no treatment group, and we've been asked to add a match duration and intensity.
Yes.
And what we're debating is, you know, if you don't have any three groups, then you can't say that either one is better than, you know, from a public health perspective than what's out there. So we're debating about whether we need to fund this to have three groups.
Yeah.
It's very expensive. You can't-
It's very expensive.
You can't do it on an R1, but
So eye care has essentially two usual and customary care groups.
yeah.
So 2/3 of the 360 sample, one is a dose equivalent usual and customary care, and the other is usual and customary care, which we're not intervening, we're just monitoring.
Right.
So, you know, they're funding this, and only 2/3, and not only, but 2/3 of the sample are usual and customary care. And part of that is because there's so little known
That's what I'm saying.
about what goes on in usual clinical care. It is all over the map. And I think we have to start to look at this much more closely. So the VA robot Silt and LEAPS trial were not designed to assess equivalency. And this is a really important point. If you want to read about equivalency trials, this is a very nice paper, Blackwelder. It's actually in the Journal of Dental Research. So that's my tie to the dental school. But they were not designed. To design an equivalency trial requires a lot more power, because, you know, you could not have enough power and find equivalency and say, well, you know, that's how that was designed, but it wasn't designed that way. All of these trials were designed with superiority. So the hypothesis was that the intervention, and now I'm going to go to the bad news.
Actually, I'm sorry, before we go to bad news, can I ask a question? So,
Bad news is actually part of good news, but that's okay.
so you talked a lot about timing in terms of when the incident occurred and when the intervention occurs and dose in terms of timing, but what about intensity? So you kind of alluded to the intensity of the different groups. And
Right.
It seems like with a robot, it's very easy to control intensity.
That's right.
You have clinicians who are ranking based on how someone's performing. It seems like that's a very important variable that
It is a very important variable, and it's still kind of fuzzy in its definition. For the robot trial, intensity was defined by the number of movements in a set period of time. So these people were treated for an hour. And so the robot got in X number of movements, and basically the human intensive matched group, you could say dosage matched, had to get in the same number of movements. So that's how that defined intensity. The home exercise group, they never really used the word intensive. I use that. But it was progressive. It was an hour long. And they were keeping that person engaged for an hour. So that's a really important.
are there measures of keeping that person engaged?
Well, certainly the documentation, and I think some of the work that you're doing is really going to get at this, you know, where we're doing much more fine-grained analysis of what people are doing. We don't have that. And so all you have is, you know, the documentation. You have, you know, your standardization where, you know, you have certain criteria that, you know, if they're going to rest, they can't rest for longer than X amount of time. I think that's how it's being done right now. So I want to talk about this issue of superiority trials. And these two trials, the LEAPS trial, and I'm comparing this now to a recent trial, a medical device trial that used stenting in people with intracranial arterial stenosis. This was the Sampras trial that my program officer was also the program officer for this trial. And he's the one who alerted me to this. So this is stenting versus aggressive medical therapy for intracranial arterial stenosis. And I've titled this slide, What Do We Learn from Negative Trials? Both of these trials were negative in the eyes of the clinical trialists. For LEAPS, locomotor training, including the use of body weight support and stepping on a treadmill, was not shown to be superior to progressive exercise at home managed by a physical therapist. The hypothesis was that it would be superior. So it was a superiority hypothesis, which is really how most of the trials now are designed. I've never seen a rehab trial that's an equivalency trial yet. So when you don't support the superiority hypothesis, it is called a negative trial. It doesn't mean it's negative in the sense that it's bad. It just means that you, using these rigorous scientific methods in the design way, it's negative. The implications of that negativity or negative trial findings are quite different between these two negative trials. The Sampras trial in patients with intracranial arterial stenosis, aggressive medical management was superior to this is called percutaneous transluminal arterial stenting. And they used this fancy wingspan stent system. And what happened was they had a superiority hypothesis for this fancy device. And what they found, though, that the aggressive medical management was superior both because the risk of early stroke after PTAS was high and because the risk of stroke with aggressive medical therapy alone was lower than expected. So I point you to the comment that Bruce Dobkin made a few months ago as we were putting together things for the ACRM meeting, that, you know, we don't deal with these safety kinds of issues. We have adverse events in rehab, but they're not life-threatening. Well, and they're not, yeah, okay, all right.
There was a...
Yes. The very first LEAP subject actually died on the treadmill. He had a coronary, he'd been done all the screening and everything else. So you have to be ready for it. But we make a list of what the expected adverse events are. And so we're working with people that have a cardiovascular disease. So we're going to expect that they're going to have secondary, they're going to have these adverse events. The critical point is, are those adverse events related to our intervention? And they actually deemed in this first patient that the intervention was not related to his death. So my point is that, we don't, usually the kinds of things that we do not directly induce second strokes. This is, however, what happened in this trial. The medical community, particularly those people that really, were wedded to this device, were not happy with these results because they really knew that their device, they wanted to do that procedure and input that device. But when you looked at it in this rigorous way, aggressive medical management was superior. In the...
So this is sort of maybe a minor point, but the hypothesis was that the stenting would be superior.
Yes. So both of these were superiority.
Okay, so it was a directional hypothesis.
Yes.
So their conclusion that actually aggressive medical management was superior was not actually based on the statistical data, but rather on
the adverse events.
The adverse events.
Correct.
Okay.
So now there is a secondary outcome paper that's coming out in LEAPS about the incidence of falls. And but in the primary outcome paper, this was not included. This sub-analysis was not included. My point here is that the clinical community was also, to some extent, wedded to this body weight supported treadmill device, and were not happy when it didn't come out superior. And so there's been a lot of discussion about the meaningfulness of this finding with respect to clinical practice. And so my program officer, Scott Janis, I think said it the best. If a trial informs, a negative trial from the standpoint of the statistics in a superiority hypothesis is not necessarily bad. If a trial informs how to treat the patient, then it was a success. So you could take the LEAPS findings and say, you have a patient in front of you, and they can't get to your clinic. So they meet the inclusion criteria that was found to be appropriate in LEAPS, but you see them as really potentially benefiting from an intensive exercise program. You could recommend to them that they have an intensive progressive home exercise program, and they would see the same walking benefits than if they came into your clinic and got into the body weight supported treadmill training and used that in addition to locomotor training. To me, that's good news for the therapy community because it says we have multiple options here. So we can practice evidence-based rehab from information that we gain from this trial. Now, the clinics that have invested in these expensive body weight supported treadmill training devices might not be all that happy with this. But I think it gives people another option. So Scott's point is that it's not an issue when it comes down to making recommendations for clinical practice. It's not an issue of whether it's a positive or negative trial. It's using the information in the appropriate way. And he said, equivalence can be useful. And he was really referring to the LEAPS trial. And I gave you an example of how it might be useful in terms of that. So one of the things I wanted to point out is that we have a consistent pattern across studies. And I've added this study here, which I didn't talk about. But essentially, the appropriate alternative, and you remember that first slide I showed you about choosing the appropriate alternative. And I said it isn't necessarily a no treatment group. In all of these cases, the appropriate alternative comparison intervention was a dose-matched therapy, was as effective as the complex intervention under study. And I think Florence, you're getting some of this from the...
I think it's permeating the whole NIH.
Yes.
We didn't even submit to the agencies that funded it. And, our study section was pediatrics, autism, a whole different thing. And it was all about...
Yeah, but it's still rehab. And I think there's a mindset about rehab trials.
Because in our study, in our pressure ulcer hyper interference,
So
it's okay, but it's just
she's blocking her ears.
I can't really say anything, but the times are different.
Right.
Very, very different.
The point I want to make here is that that is sometimes missed is the appropriate alternative was not standard practice in any of these. And I think that's really the important message for the clinician out there. That our level of standard practice right now is not meeting what we know from the evidence. It's not there. And I think that's a really important point that I think we as academics in rehabilitation with our colleagues in clinical practice have a responsibility to get this message out there. So what have we learned from this that can inform where we're going? I think so in some sense I see this as turning the bad into good. The focus has been on showing feasibility and efficacy for various devices and interventions, FES, robotics, constraint-induced body weight, task-oriented training. I think it's time to shift our questions from does it or can it work to asking how, why, and for whom does it work? I think we've missed the boat. We were so eager to say, our interventions work, and they're good for rehab. Well, okay, we're past that now. We really need to start looking at this whole notion of personalized interventions that are grounded in new knowledge of prognostics and assessments. We have to do a better job of prognosticating. Who is going to respond? Who are the responders and the non-responders? I think given that the median time from theory to practice, if you think about the stages, is estimated to be about 24 years, and this was a recent publication, I think we need to capitalize on the momentum from these landmark intervention studies. None of them were perfect, but they really represent a progression in our understanding of how to do clinical trials in rehabilitation. It's not simple. And we need to move the field forward with efficiency and with wisdom. So what we choose to do, I think, is very, very important. So the bad news, then, that dosage appears to be more important than the therapy paradigm. I think we have to face that. We think our therapy paradigms are so, unique, and they do this and they do that, but we haven't been able to show that. It really is coming down to dosage and intensity. There is really a limited scientific basis in neurorehab to identify the critical ingredients of therapy at a high enough resolution. We're not able to do that. We put in the iCare trial. We wanted to compare two interventions. We wanted to compare our accelerated skill acquisition program to the signature constraint induced movement therapy program, and then we had a usual and customary care group, and they didn't want any part of it. They weren't interested in that. That was really more like a phase 2 type trial, where we're trying to get at the specific ingredients of the intervention. And, as Florence said, trials are very costly to conduct, and I really think that peer review is driving the design of the phase 3 trials. I think we have much more flexibility in the phase 1s and the phase 2s, and I think we need to not be so greedy in going for these phase 3s because they're so, they bring in so much money, and we need to go back down to the drawing board and start designing really good phase 1, phase 2s. We're doing, I think, a really superb phase 1 on dosage. We don't know what the dosage is. I mean, that people pick dosages out of the woodwork, and we don't know that. And we know intuitively that people are going to respond to different doses. Some people might need more. Some people might need less. Why not be thinking along those lines than trying to fit everybody into this, a standardized protocol that is well defined and at the phase 3 level? We're not there yet. So there's also little clarity or consensus on standard outpatient therapy, which is where often we're intervening. I think this is a whole area that would be incredibly exciting to explore, and I think a lot of the methods that we have could do that quite well. A lot of the continuous monitoring kinds of things could be done. All right, now I'm going to share with you one ugly piece of news. I don't really think it's ugly, but it was very, very clever. And this was the Cirros trial. Bruce Dobkin. This was an international RCT. It was a phase 2 of stroke inpatient rehab with reinforcement of walking speed, and improves outcomes. So background, feedback about performance may optimize motor learning after stroke. No brainer, right? That was. So we wanted to develop an international collaboration to rapidly test the efficacy of daily verbal feedback about walking speed during inpatient rehab after stroke. Very simple. Very straightforward. No one had ever done this before. Single-blind, multi-center trial randomized inpatients to either feedback about self-selected fast walking speed, daily reinforcement of speed, this was in the inpatient setting, immediately after a single daily 10-meter walk, or no reinforcement of speed after the walk, performed within the context of routine physical therapy. Now, how hard do you think it was to get sites to participate in this? It was not hard at all. He got 18 sites. And you know why? Because standard clinical practice doesn't normally give feedback about gait speed. The clinician walks the patient, says, walk this, and then they go and write in the chart. And forget the fact that, gee, maybe if I told the person how they did and compared, told them that, last week they were going at this speed, that maybe that would have an effect. And that's such a, it's such a fundamental principle of motor learning. But there hadn't been a trial on it, so people weren't incorporating it into clinical practice because there hadn't been an RCT on this simple concept. So within 18 months, he gets 179 participants randomized across 18 centers internationally. I mean, there were sites in, Jordan and Israel, and all because we have, internet access. And we can, we can input data like that. And guess what? The walking speed at discharge was 0.91 meters per second. It was greater than that for the no reinforcement of speed. So the conclusion was, for this phase 2 trial, an internet-based collaboration of 18 centers found that feedback about performance once a day produced gains in walking speed large enough to permit unlimited, slow community ambulation at discharge from inpatient rehab. Did it take a trial to show that? I mean, none of you are surprised by these results, right? What's surprising to me, and that gets back to this whole notion of the state of clinical practice, is that this very simple concept was not something that is part of standard care. So the ugly news is that standard clinical practice is really slow, glacially slow in my view, to incorporate evidence-based principles of practice and motor skill learning even in the most basic strategies. We're so focused on these complex interventions, we forget about these very simple manipulations. I think understanding the developmental phases of RCTs is not universal. I think we need to bring this much more into our education system. I think this T32 is a great opportunity to educate people about this process. I think the healthcare delivery for neurorehab is changing. It's unstable and variable across centers, shorter stays, there's new criteria, and this is going along with our research that's happening, and we need to have a better connect. I think I'm gonna do 2 more slides and then I'm gonna quit. But the challenges to successful clinical trials clearly are recruitment. I think we have that one pretty well under control. We've really learned a lot, and very close monitoring is very important. The clinician's time and commitment to standardization and restandardization throughout the trial period to prevent drift is really unique, I think, to these behavioral and complex intervention rehab trials. It's a very, very important part. That's a whole nother story, but I think it's clearly something that people need to understand from the get-go. The need to embargo the investigational intervention to prevent contamination across treatment arms. I think Florence can appreciate this. I appreciate this in my eye care trial. And this is something that the clinical community, I think, doesn't completely understand the importance of. Training clinicians to use a principle-based intervention. In other words, an intervention that's based on principles can be much more challenging than a fixed protocol-based intervention. This is something that we're realizing as part of the eye care trial. I didn't talk about this, but I think it's a very important part of where we're going. The hidden benefits and opportunities are the tremendous collaborations. I've had an opportunity to collaborate with just a tremendous group of folks that has really made what we do meaningful and really enjoyable. The spin-off projects, imaging, motor control, healthcare economics, genetics, I think creating the infrastructure, the platform for future clinical trials and rehab is really, really important. The opportunity to participate in writing teams for various secondary publications. One example is the nature of usual and customary care for outpatient stroke rehab. Looking at things like who are responders and non-responders. These are all secondary analyses. and the opportunity to learn up close and personal about clinical trials in neurorehab. I was going to go through 2 examples. I'm not going to go through them, but I think you can read about these. This was a wonderful secondary analysis that Sarah Mulroy led of the STEPS trial. They basically did a sub-study. They took 15 subjects from each of the 3 body-weight supported treadmill training locomotor groups and looked at details of the kinetics of their walking. And the other one just came out earlier this year. This was a secondary mediation and regression analysis of the PT Clin ResNet database. Now that we had this full database, we looked at the causal relationships among the ICF levels for the 4 trials intervention. And so I recommend those. What is the future? We need to know about functional prognosis and the clinometrics of our assessment. I think we need to move towards translational and mechanistic research. So, for example, what do patients learn when they recover function through our interventions? We can't answer that question yet. We need to know what mechanistically is changing to improve on what we are doing. We need to understand the importance of findings where outcomes might be similar, but neural mechanisms might be different. And I point you to this wonderful paper by Jill Whittle. And I think we really need to focus on bridging the gap between the preclinical and the clinical research. And this might mean we have to change our models and our way of thinking about how we go about this. And I pull this quote from, this was Quackel's group. And he summarized in a recent Lancet paper the developments in stroke rehabilitation. He said, major advances have occurred in the past 20 years in the development and testing of interventions, but there are many gaps and shortcomings in the evidence base to inform clinical practice. And I think we need to fill those gaps. And I think we can. This is one of my favorite pictures of Stephen Hawking, who said, I want to go in the vomit comet. And they said, well, there's no way you can do this. They said, okay, we'll let you up once. He ended up going in about 5 times. And he enjoyed it. And I would like to acknowledge all of my colleagues. I particularly want to acknowledge the Division of Biokinesiology and Physical Therapy, Jim Gordon, for providing a lot of the research infrastructure that has allowed me to do the work that I love. And that comes in the form of other funding, additional funding, funding for people who are working on the grants. We found this in PT Clin ResNet. I think it's a very, very important point that's often misunderstood. And that's my favorite. Thank you.